dear colleagues, dear friends, dear chairmen, I regret that I can't be in the symposium myself, but I am pleased to present my topic, strengthening TB diagnosis and treatment, implementing WHO and TB strategy after 2050. The main issues for our discussions I have post 2050 NTB strategy and goals, tuberculosis action plan for the WHO European region 2016-2020, MXDR TB, the challenge in the WHO European region, early diagnosis of TB, including the use of rapid tests, WHO strategy on MXDR TB treatment, guidance on new drug introductions. 67th World Health Assembly accepted post-2050 NTB strategy and its goals. You see on this picture the global plan for 2060-2020 and sustainable development goals, which was accepted. Global progress on TB control, we can see during the previous strategy 47% drop in TB death rate since 1990, 43 million lives saved between 2000 and 2014 through the effective diagnosis and treatment. Tuberculosis action plan for the WHO European region accepted for 2060 and 2020. And I will focus on the European plan. The vision for this plan and to tuberculosis epidemic with zero affected families facing catastrophic costs due to tuberculosis, the goal to end the spread of drug-susceptible and drug-resistant tuberculosis, achieving universal access to prevention, diagnosis, treatment in all member states in Europe region. Target is 35% reduction in tuberculosis deaths comparatively with 2015, 25% reduction in tuberculosis incidence rate, and 75% success rate among the MDR-TB patient cohorts. It should be achieved until 2020, and it is a quite short time, and very much we should do during these years. The areas of intervention is integrated patient-centered care and patient prevention. This is an area we will focus on today. Systematic screening of contacts and high-risk groups, early diagnosis of all forms of tuberculosis and universal access to drug susceptibility testing, including the use of rapid tests, equitable access to quality treatment and continuum of care for people with tuberculosis, including drug-resistant tuberculosis, and patient support to facilitate treatment adherence, collaborative tuberculosis HIV activities, management of latent tuberculosis infection and preventive treatment of persons at high risk, and vaccination against tuberculosis. The second area of intervention is bold policies and supportive systems. The political commitment, health system strengthening, regulatory framework for case-based surveillance, vital registration, quality and rational use of medicines and pharmacovigilance, airborne infection control, community system and civil society engagement, social protection, poverty alleviation. The last is intensified research and innovation. Discovery, development, and rapid uptake of new tools, interventions, and strategies, and research to optimize implementation and impact and promote innovation. MXDR-TB is significant public health challenge in the Europe region. Estimated percentage of MDR-TB among new and treatment cases you can see on first table, and you can see Estonia, Lithuania, and Latvia, same percentages of MDR-TB among new, light blue, and dark blue among retreatment cases. 15 from 2017 countries worldwide with high burden of MDR-TB are in Europe region, and on this table we see Europe region. Treatment success rate for MDR-TB patients enrolled in 2012 is on second table. The cure rates in Estonia, the first country with highest rates of cure, 74%. In 2013, Latvia also achieved 74% of cure rate. And for Lithuania, I don't have new results, but you see here. And Europe region, in average, have 49% of cure rate, which is very low comparatively to the WHO aims for MDR-TB cure. It's 75% for MDR-TB patients, and it should be achieved until 2020. You see on these slides the latest WHO updates to treatment guidelines for drug-resistant tuberculosis. And drug resistance is most severe in our countries to stop spread of MDR-TB and to achieve better results. And in this new updated guidelines in 2016, there is a statement that rapid drug susceptibility testing of at least rifampicin is recommended in adults and in children over conventional testing or no testing at the time of diagnosis. This is a strong recommendation. So we should use rapid detection with gene expert. We should use conventional rapid tests as well. There you see the expert MTB-RIV assay and the different type of modules for platform of expert. It detects TB and rifampicin resistance. It can be used as standalone diagnostic test. The test requires uninterrupted, stable electricity supply, yearly calibration of module, ambient temperature, cartridges and reagents, and well stored these reagents. The test cannot be used for monitoring treatment. So anyway, we need to do cultures and DST results on liquid or solid media. For rapid detection, XDR-TB policy guidelines issued in 2016. For patients with confirmed rifampicin resistance by gene expert or by other tests, second-line LIPA may be used as the initial test instead of phenotypic culture-based DST to detect resistance to fluoroquinolones and to detect resistance to the second-line injectable. Using these methodologies, we can detect patient very early with MDR-TB and with XDR-TB and start treatment, appropriate treatment, very early for this patient. It stops transmission and it improves patients' treatment and treatment outcome very much. Here you see how genotype MTB drug resistance second line is used, and we see that there is two versions and can detect resistance to amyloglycosides, cyclic peptides, fluoroquinolones. WHO strategy on MXDR-TB treatment and guidance on new drug introduction have issued several important guidelines for new drug introduction for bedaquiline, delamanid. There is also policy implementation to support countries to rule out new drugs for treatment. This is policy implementation package, and this also supporting for implementation. Companion handbook issued 2014 and updated 2016 altogether is very useful new guidelines, including all treatment regimen, including how to use new and repurposed drugs. Also, there is additional important guidelines from SWIFT project, very well described use of new drugs, NTB clinical and programmatic guide, also for short treatment regimen, how we can use new treatment regimens with new drugs, repurposed drugs, and rapid advice for children management with drug-resistant tuberculosis. WHO in last update recommends the short MDR-TB treatment regimen. It is the first time that WHO recommends implement this type of treatment regimen. Total, it's 9 months regimen up to 12 months, and there is a criteria for patients who can receive this short treatment regimen, and this is patients who have good DST, spectrum of DST, and have sensitivity to fluoroquinolones and injectables and other second-line drugs. In these guidelines also we see new grouping of second-line drugs for easier to use when choosing treatment regimen. And there's some differences. There is group A, B, C, D instead of 5 groups. There is fluoroquinolone group, second-line injectable group. Other core second-line agents is expanded, including additional to etinamide, protinamide, cycloserine, tersidone, include linezolid and clofazimine. And when we choosing treatment regimen for conventional 20 months regimen or for short treatment regimen, we have possibility to include more drugs, more we can choose to have the 5 drugs in treatment regimen. D group have 3 subgroups, including first-line drugs, first-line drugs, new drugs, and other drugs which is weak but still used in treatment regimens. Conventional MDR-TB regimen, therefore, is regimens consisted of 5 effective TB drugs during intensive phase, including pyrazinamide, and 4 core second-line drugs. 1 choose for group A, 1 from B, and at least 2 from group C. It's easy. Pyrazinamide, if it's compromised, can be replaced with another drug. There is a suggestion from another sources for grouping of XDR-TB and pre-XDR-TB and other patients who have not possibility to have good treatment regimen, combine treatment. You see that in green color, this is a drugs which is added or replaced in the conventional treatment regimen of second-line drugs. For XDR-TB, you see the backbone XDR-TB treatment regimen include new repurposed drugs, supportive drugs, and pyrazinamide. So it becomes available to choose for every patient good treatment regimen if we have access to all drugs. So there is a need, political will, funding, support for donors or other to establish for every patient, not leaving untreated patients on palliative care. Patient-centered care, it means that every patient should receive the best treatment option which is necessary for these patients, not only with treatment regimen according to DST patterns, treatment tolerance, other diseases which can compromise treatment. There is also where and how we can take care for patients, let patients to choose place and also decide where to treat in hospital, and we will treat very sick patients, of course, in hospitals. But patients who are not very sick and can go to ambulatory department or healthcare workers can come at home to provide treatment. These patients could stay home. It is much better for patients because there is no possible cross-contamination and transmission of new infection. Many hospitals lack of these infection control measures, and this is a risk. Hospitals cannot supervise treatment and follow up patients after discharge. It is, there should be a mechanism how to implement. Outpatient MDR-TB treatment team decides how to clinically manage patients with drug-resistant TB. In clinical visits, when patients come to clinic, DRT at home, other places, like internet-based, Skype-based. Psychosocial support, patient education should be provided. Then it can become a treatment via prescribing, have good results. Introduction, integrated patient-centered care and prevention of rapid diagnostic, new drugs and regimen with case management for treatment, drug-resistant tuberculosis offers us the opportunity to do our best work. This is a chance to move away from the goal of preventing resistance to goal of supporting optimal introduction of new drugs to ensure the best possible outcome for patients and programs. And I wish you to achieve this, to have the possibility to treat and to cure every patient you have. Thank you very much for your attention and have successful continuation of symposium.